Here is your stem.
I'm ready, ma'am.
Okay, so if you've read and understood considering it critical care scenario, please tell me how are you going to manage this patient and what provisional diagnosis would you consider?
Okay, my provisional diagnosis would be gastric outlet obstruction, and it could be either due to benign causes like peptic ulcer, chronic peptic ulceration, or malignant causes like gastric or pancreatic cancer. And I will manage this patient according to CCRIS protocol with ABC. And I will NPO the patient, and I would give patient crystalloid solution like sodium normal uh, uh, injection normal saline infusion along with the potassium supplementation.
Okay, then please comment on the blood labs of this patient.
Patient has severe hyponatremia where the serum sodium is 125, potassium is at 1. Patient also have hypokalemia,
Yes,
hypochloremia, is showing alkalosis.
yes. What might have caused this condition?
So, in gastric outlet obstruction patient with these serum electrolyte findings and pH of alkalosis, my diagnosis is hypochloremic hypokalemic metabolic alkalosis.
Yes, but then how are you going to take care of that?
Uh,
Patient
I
is a
will.
base balance.
Yeah, so I will give patient injection normal saline infusion along with potassium supplementation. I would also give patient antiemetics so that the sodium and chloride and that is being lost in vomitus that gets better, and I would also uh, keep the patient in critical care.
What might be the provisional or the provisional diagnosis or the conditions that might have led to this condition?
Yes, so chronic peptic ulceration can cause hypertrophic pylorus that causes the gastric outlet obstruction. And
Yes.
if there is any gastric or pancreatic cancer, that can also lead to gastric outlet obstruction. And the same.
Help me
Will-
or walk me through the pathophysiology of this condition.
So uh, the chronic peptic ulcer is either is caused by H. pylori that can cause the mucosa damage to the mucosa, and it loses its function as a barrier. And there are few drugs such as non-steroidal anti-inflammatory drugs that can also cause the ulceration in the duodenum or the
What
stomach.
is the effect of this ulceration? Just say if you're talking about peptic ulcer, then peptic ulcer could either be in gastric region or in the duodenal region, right? First
Okay,
part of the
okay,
duodenum, right?
okay.
So
So
what
yeah.
exactly is happening?
Okay, so first of all, there would be inflammation, and then there would be fibrosis and repair. And due to the after the inflammation, the fibrosis and repair causes the hypertrophied, narrowed part of the pylorus that does not allow the stomach contents to pass to the duodenum.
And that leads to obstruction.
Yes, that leads to obstruction and vomiting.
Okay, these symptoms occur. All right, okay. Please tell me, how would you classify? You said patient has hyponatremia. How would you classify hyponatremia? If you can possibly give me some examples.
Yes, it is classified on the basis of the number. If it is between 130 to 135, that is mild. If it is between 125 to 130, that is moderate. And if it is less than 125, then it is severe hyponatremia.
Okay, there is also on the okay, and there are conditions as well, like because of depletional, dilutional
Yeah, these are types. Yes.
condition.
So osmolarity, if it is between 270 to 90, that is considered a normal osmolarity. If it is less than 270, it is hypoosmolar. If it is more than 290, that is hyperosmolar. So hypernatremic, hyperosmolar hyponatremia is caused in hyperglycemia when there is mannitol given, when there is sorbitol given, and then there is isoosmolar hyponatremia, where the cause is hyperproteinemia,
Okay, if you
hypertriglyceridemia.
fail to manage this patient, what are the complications of this hyponatremia that you can witness in the patient?
Okay, the first and foremost is the CNS. Patient can have agitation, confusion. Patient can have seizures, or patient can have decreased consciousness. And the other system that are affected by hyponatremia are the cardiac and the renal. So patient might end up having cardiac arrest or arrhythmias, or
Okay.
patient can have a
What
renal
is the
failure.
mechanism behind patient's hypokalemia?
So hypokalemia is patient is having, due to the hypovolemia, patient is having secreted the angiotensin aldosterone system, activation of angiotensin aldosterone that causes the sodium and water to be reabsorbed, and potassium and hydrogen ion to be excreted, that causes the hypokalemia. And patient also have loss of chloride from yes, I think this is the cause.
Okay. Do you think you would have to operate on this patient and when?
Yes, after the patient the electrolytes have been managed, and if there is the obstruction or the hypertrophy of the pylorus is so severe that patient does not have it cannot be managed with medication, then definitely patient needs to be surgically explored, and we do a specific procedure for this that is called pylorus myotomy. We can do pylorus myotomy in this patient to get treated from hypertrophic pylorus.
Okay, there is another substance that can be increased. Which one is it and why?
Okay, yes, that is
Bicarbonate,
bicarbonate, because
yes.
yes, because to neutralize the chlorine
Yes,
deficiency, the bicarbonate increases in the blood by renal tubular absorption.
yes. And there'll be reduction of another.
Yes, there would be reduction of sodium
Why? Because of.
because to neutralize the alkalinity, the blood alkalinity, sodium bicarbonate is excreted in urine, so it causes hyponatremia.
Yes, okay, that is being released or that it is being excreted by the kidneys. But what's another thing is happening that this bicarbonate is rich in pancreatic juice. So what would happen at the level of intestines because the level would be more will be
Yeah.
excreting.
So
So
as
they will
uh,
be retaining it instead.
yes, because there is obstruction, there is no acid going down the
Yes,
duodenum that
that's
causes
what I
pancreatic juice.
yes,
Yes.
that's what I wanted you to explain. Good. Okay, thank you so much. Could there be any other procedures that can be done other than the one you've mentioned?
Sorry, ma'am, your voice was
Yes,
missed.
I asked you, would there be any other procedure or any other way we can manage this patient?
Hello.
Yes, do you hear me?
Yeah, now I can hear you, ma'am.
Is there any other procedure that can be done other than the one you've mentioned?
Can't think of it now, ma'am.
Okay, what about truncal vagotomy and gastrojejunostomy? Have you heard of it?
Chronic peptic ulcer, that can be done, but for the
Or the
hypertrophic,
peptic
yes,
ulcer disease?
yes, that can be done.
Yes,
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 selective vagotomy, truncal vagotomy, they all
yes, for peptic ulcer disease. Because
can be
this
done.
is the end result, but before that, we can manage it like that. Okay, thank you.